Yeah.
We got it. It'll be fine.
Yeah. Okay, welcome. This is our limited literature synthesis for our fall presentation. Our eco question is for hospitalized patients, does a fall prevention protocol during a hospital stay reduce the incidence of falls compared to no protocol? So our patient population is hospitalized patients. Our I is the implementation of fall prevention protocols. Our C is the fall prevention protocol versus no protocol, that comparison between the two. And the outcome is reducing the incidence of falls themselves. So, okay.
Okay, so for my article, I did this article by Radke, Reynolds, and Kara, and it's about inpatient fall prevention from the patient perspective. And it's a qualitative study. So the population size and studied is there were 7 men and 5 women. The ages ranged from 38 to 89. 3 of the patients were hospitalized in a medical progressive care unit, while the some other 3 were on just regular medical units, and then 6 were on surgical units. So prior to hospitalization, 11 of the 12 were living independently without assistance, and 1 was living with the caregiver and required assistance. It took place in a large urban tertiary care academic health center in the Midwest, and it didn't really give any specifics of where that was. The design was a phenomenological, qualitative study, so was a living experience while in the hospital. The purpose was to see the effectiveness of fall prevention protocol through the eyes of patients. And the results were that current fall prevention programs are well intentioned, but they may fail in practice because of the mismatch between our view and those of the patients. So they think that the current fall prevention programs are more from the clinician mindset versus a patient mindset. The evidence level was a level 3. The quality rating was good quality. And implications that we can take into our future nursing practice could be implementing fall prevention protocols that are individualized to your specific patient so that it can be effective.
Yeah, so for my article, it just kind of was an overarching article looking at the prevention of falls in hospitalized patients. So it didn't have a specific size or setting because it wasn't a research study. So population was hospitalized patients. The study design was a non-research quantitative study. And the purpose of it was to evaluate the state of science regarding fall prevention in hospitalized patients. Overall, the results of the article showed that various fall prevention strategies commonly used in hospitals, such as alarms, sitters, intentional rounding, patient education, and environmental modifications, physical restraints, and non-slip socks. It looked at those things. However, it highlighted that many of these strategies lack strong evidence in effectiveness, and it had mixed results from studies. And for instance, it showed that alarms have shown little impact on reducing fall rates and can even contribute to patient agitation and potential restricted mobility. And they also found that sitters lacked evidence of effectiveness and can be costly. And then intentional rounding has weak evidence supporting effectiveness in reducing the risk of falls. Again, with patient education, environmental modifications, physical restraints, those provided a mixed evidence of effectiveness. My evidence level was a level 5. The quality rating was high quality. It showed a comprehensive overview of various fall prevention strategies and synthesized evidence to evaluate their effectiveness. And then some implications for future nursing practice and future research. The article highlighted the need for just well-designed research studies in hospital fall prevention, and it suggested, well, that there are various strategies used. A lot of them lack evidence, so that they suggested in future research that they should focus on doing studies to evaluate the effectiveness of these strategies in preventing falls. Additionally, they talked about the importance of considering the unique characteristics of hospital settings and different patient populations when designing a specific fall prevention intervention.
And yeah, my journal article looked at more of a cross-sectional approach to the fall prevention strategies and their implementation across a variety of different hospital units. They looked at 60 different med-surg units over a variety of different teaching, urban, and nonprofit hospitals. And this is a sort of quantitative study looking at which prevention was sort of the most effective versus ones that were less effective. The results showed how like keeping the bed locked, the room door opened, discussions about post-fall rates, and staying with the patient while in the bathroom are all effective strategies to more likely reduce the fall rates in hospital units. It's a level 1 evidence level, so it's strong. I'd say this is a high quality rating after doing the research on it. The implications seen in practice is how nurses should prioritize consistently if using effective measures like maintaining locked beds to ensure regular application. I think recognition of challenges associated with time and sensitive interventions underscores the need for innovative solutions, driving future nursing practice towards tailored fall prevention protocols based on unit-specific factors and patient risk profiles. Sort of the future research that can be done based off this is looking at exploring reasons behind variability in implementing intervention strategies, especially in time-sensitive ones, because there's going to be times when you're not going to be able to implement more effective strategies than less effective strategies. It's just how it goes in those hospital units. And so examining implementation qualities, impact on fall rates is crucial for refining protocols. So
next we have fall prevention in hospitalized patients, kind of looking at falls through nursing outcomes classification. So the population size and setting, it was 68 adult patients, and they were all over the age of 18, so adults. They were hospitalized in clinical and surgical units, and this was within 24 hours post-op. And so at that point, they're at high risk for falls based on their MFS score. The study design, it was a quantitative cross-sectional descriptive study, and it evaluated the nursing outcomes that helped to prevent falls to improve patient safety. And so they're focusing on 5 nursing outcomes specifically, and there are a lot of other ones, but they just focused on 5 for this study. It is a level 3 evidence, so pretty strong. The quality rating, it was good quality. The results were pretty reasonable with the study. They kind of showed how they had the 5 outcomes that they were looking at, and they used the Likert scale to measure that. And it was concluded that overall patients had a limited level of knowledge regarding falls, which is why it was important to educate patients. And some implications for future nursing practice and research. It's important to assess a patient's knowledge about falls and looking at how specifically medications can impact their risk when they're in the hospital, especially post-operatively when they're receiving a lot of pain medications. Another thing with the research is that a lot of the nursing outcomes could be evaluated. You could evaluate different ones based on which outcome you choose. And additionally, since the study did not have patients who had cognitive impairment, they could also be assessing that to see how that would impact the overall patient falls. And then for our summary, some themes were fall prevention protocol on paper is effective. However, since every patient is unique and not likely to fit the same criteria that the fall prevention protocol generalizes, it's less likely that it reduces falls overall. And so since every patient is in a different circumstance, their level of understanding will be different post-operatively and with falls. And our research shows that even policies that have been in place for a decent amount of time that aren't effective, like non-slip socks, bed alarms, other things like that. The only policies that are really effective are reducing fall risk, but have not been proven cost effective. And they also do not consider the staffing on the unit, and also with like one-to-ones, bed locks, things like that. So it's important to consider all of the different staffing on the unit when looking at this. And our range of the levels of evidence were level 1, level 3, and level 5.
Yeah, so overall significant findings that we saw throughout all of our articles was that proper education and implementation of fall prevention protocols that is patient-centered and individualized to that specific patient reduces the likelihood of falls. And if we control implementing the same protocols without reform, we will not reduce the likelihood of falls. If fall prevention protocols are implemented in a way that is patient-focused and explained well to the patients, they reduce the likelihood of falls. However, if the patient is unaware of the risk and not properly educated, the likelihood of them falling is higher, even with the protocols in place. Some overall strengths and limitations that we saw from our article. The strengths included a diversity of research design types and randomization of control groups, which allowed our research articles to demonstrate how the results showed validity. And then some limitations were that there was selection bias, excluding patients with cognitive disabilities and mental impairments, excluding patients who don't speak English, excluding bedridden patients, and only specific to one unit.
And then finally, our overall implications for future nursing practice is how we can look at fall prevention protocol and understand that it needs to be followed to a T to be effective. However, since every patient is individualized and it's hard to follow it exactly, specific protocols can be difficult to navigate. Nurses need to recognize that implementing strategies that are cost effective and more likely to reduce falls like bed locks and staying with the patient while in the bathroom cannot always be obtained. And so just trying to tailor your fall prevention protocol for your patients individually to best support them while they're in the hospital. Some overall implications for our future research would be considering what other protocols could be implemented to reduce the likelihood of falls that are different from the ones in place right now. So and if we can like add any that would work better than the ones that we have, and how we can adjust and change the protocols in place to be effective and patient specific to keep our patients safe. And that's all that we have.